Well, thank you, Hank, for that most generous introduction, and thank you all for the opportunity to be here. And I would emphasize also what a privilege and pleasure it is to be here once again for what's the 6th annual Caring Community Conference, and to be associated, Dean, with the Center for Global Health and Diplomacy of the University of North Florida. The World Medical Association was founded in 1947. It's a global federation of some 100 member countries representing millions of physicians worldwide. And acting on behalf of patients and physicians, World Medical Association endeavors to achieve the highest possible standards of medical care, education, ethics, and health-related human rights for all people. Now, in the time we'll spend together, what I'd like to do this morning is two things. The first is to describe, because I think we need to look at them again, some of the main types of healthcare systems and make observations about the status of delivery of healthcare around the world. And then second, to make some predictions about what I believe will be the primary forces that will determine the nature of healthcare globally and here in the U.S. Now, globally, healthcare systems, regardless of who they are and where they are on the move. Even in countries that have systems with which they are happy, are constantly making changes, tweaking to make improvements. And the major focus worldwide is in trying to control escalating costs. So it's not just our problem, and it's a problem regardless of the type system that's in place. And countries without organized healthcare systems are looking at how to achieve universal care for their citizens. Healthcare systems are deeply rooted in each country's cultural ideas about society and values, and whether one model works for a particular country depends on that country's goals and values. In other words, there's no evidence that one model is particularly better than another unless you put to it that measure of what you want to achieve and also whom you trust. So globally, there is no uniformity, and there is total inequality. Some countries have systems to care for their population, others don't. In fact, of the approximately 200 countries in the world, only the 40 economically developed countries have organized healthcare systems. Because of this, the majority of people worldwide never see a doctor in their whole life. Now, that's hard for us to imagine, but that's the reality for the majority of people worldwide. In addition, the rich countries in this world meet their need for health professionals by a brain drain, if you will, basically recruiting them or borrowing them from poorer countries. Now, this is a satellite picture of the Earth at night, and as you can imagine, what it demonstrates is the distribution of electricity around the world. I would suggest it is similar to the distribution of the medical workforce and healthcare systems in healthcare, illustrating large areas of Africa, Asia, some of rural South America, in which the availability of healthcare and health workers does not match the size of the population. Now, the vertical axis on this graph shows the percent of the global burden of disease in different continental regions. The horizontal axis shows the percent of the global workforce in each of these regions, and the size of the balloon represents healthcare expenditures. So to pick the extremes, the top left corner, Africa, which has 25% of the disease burden, has less than 5% of the global workforce, and its healthcare expenditures, as measured by the size of its balloon, are minuscule. On the other end, the far right, the Americas, primarily the U.S. and Canada, have only 10% of the disease burden, 38%, over a third of the global workforce, and the size of the balloon, you can see, spend a lot on healthcare. Now, aggravating this difference is the issue of workforce migration and recruitment. And let me emphasize that a lot of it really is migration rather than recruitment. Physicians want to come to America to practice. Now, this chart illustrates the percent of physicians in economically developed countries like ours who were trained abroad. So just to mention a few on the left side there, 34% of New Zealand physicians were trained abroad. 32% of those in Great Britain were trained abroad. 28% in the U.S., practicing in the U.S., were trained abroad. This slide, this chart, shows the percent of physicians from countries, their physicians who are working abroad. So for South Africa, 38% of the physicians who were originally from that country are working abroad. Ghana, 29%, Angola, 19%, Nigeria, 12%. All of these are countries that you saw which have a disease burden which is high and a healthcare workforce which is inadequate. In short, the countries least able to afford this brain drain. Now, this chart illustrates the global migration of physicians. The point of the arrow is the direction. The size of the arrows reflect the magnitude of the migration. Now, to shift gears, one way of characterizing healthcare is to talk about how it's paid for. And the list is fairly long. It includes financing of healthcare by government through tax revenues, what is called internationally social insurance, or basically insurance that's paid for by employers and employees through payroll deductions, voluntary or private insurance, out-of-pocket payments, donations to and from charities, and public-private partnerships and market-based financial transaction taxes. For example, there are 29 countries who have joined together to put a tax on airline tickets, which is now being used in 90 countries around the world to help pay for HIV AIDS treatment. Now, I think that another way to characterize healthcare, and maybe a simpler way, is to look at the systems. And for practical purposes, there are four basic systems. I think it's important to point out, though, that very few countries have pure models of any of these. Most are a mixture, and as I'll highlight later, in the U.S. we have some of every one of them. They are what's called the Beveridge or government-run model, the Bismarck or mandatory insurance model, the national health insurance model, and the out-of-pocket model. And let me just briefly describe those. The Beveridge model is named after a prominent social reformer and was instituted in Great Britain following World War II. This is the prototypical single-payer government-run healthcare system financed through general tax revenues. There are no payments for the most part by patients. Hospitals and clinics are for the most part owned by the government. Doctors are for the most part government employees. For example, general practitioners are paid through capitation, that is, the number of patients they see, and specialists are paid, non-general practice specialists are paid by salary. And there are few co-payments primarily for imaging services, but by and large, there are no bills. This is the model in Great Britain, Cuba, Spain, most of Scandinavia, and New Zealand. And parenthetically, is the model in Hong Kong. The significance of that is that when mainland China took over Hong Kong, this was something that the Hong Kong citizens refused to give up. Now, the next system is called the Bismarck system. It was put in place, and that is private insurance. It was put in place in the 19th century by Count Otto von Bismarck, who was founder of the German Empire. This system includes mandatory insurance, an insurance mandate, which is financed by employers and employee contributions through payroll deductions. This country's insurers are required to cover everyone, and they are not-for-profit. There's a single payment system that's negotiated on a regular basis between the physicians union, and the insurers. Doctors and hospitals are private, and this is a model which is characteristic of Germany, of France, Belgium, the Netherlands, Japan, and Switzerland. The third model is what's called national insurance, and this is government-run insurance, which is financed by taxes and our premiums, which everyone pays. We're most familiar with this as the Canadian system, which was put in place in 1994. There's a single payer, that's the government. Providers are by and large in the private sector, although most hospitals are publicly funded. Costs are controlled by limiting medical services for what they'll pay for and making patients wait, the proverbial queue. And this is the model for Canada, Taiwan, and South Korea. The latter two are more recent adoptees of that model. And then the fourth general model is that found in underdeveloped countries, and that's that have no healthcare system. It's called out-of-pocket. If you have something in your pocket, you can get healthcare. And this includes the majority of the world's countries with the majority of the world's people. Those who can afford it get medical care. The poor, by and large, stay sick or die. And as I indicated earlier, millions of people go their whole lives without seeing a doctor. Their access is at best to a village healer or home remedies. And this includes, as I mentioned earlier, rural, primarily sub-Saharan Africa, India, mainland China, and Latin America. Now, if you're in America, you have some of everything, and we are actually, in that regard, not like Goldilocks. We'd actually like some of the potteries, regardless of what it looks like. So if you are a veteran, a hero of our armed forces, or if you're a Native American Indian, your care is basically the system that's found in Cuba, government-run, Cuba and Great Britain, government-run single payer. If you have employer-provided insurance, that you basically have in the system, you're in a system which looks like Germany, France, Japan, Switzerland. The main difference, one of the differences, of course, being in those countries that has been required for a long time. Those of us, and I say us advisedly, those of us who are on Medicare, that system is most like those found in Canada, Taiwan, and South Korea. That is, government or national insurance, which is paid for by contributions or payments from the taxpayers as well as taxes. And if you are uninsured, the 16% in America who are uninsured, it really is like being in those underdeveloped countries like Cambodia and rural India. So to reiterate, all of these systems are in constant change, none are static, and most are really a mixture. I've highlighted the main models, but most are a mixture. They're all rooted in cultural ideas about society and values. And more important than any one or the other feature is arriving at a national consensus. For example, in Switzerland, they had a referendum back in 1994 and adopted the system they have now. And it is a question, in the end, of what values are most important. So, freedom, choice, social protection, profits. Again, I think one of our challenges in America is we've had trouble prioritizing those choices, and without prioritizing, it's hard to get a choice that you will be comfortable with. Now, what other economically developed countries have decided is that universal access, at least for them, trumps other considerations. What all economically developed countries, including our own, share in common is that health care represents a significant part of the economy and the costs are continually rising. Among the Organization for Economic Cooperation and Development, the OEDC, countries, whether you're talking about the average healthcare spending per capita over the past 30 years as depicted in this slide, or in this slide where you're talking about spending as a percentage of gross domestic product, the numbers, percentages are significant and rising all the way from somewhere in the range of 6 to 7% of the gross domestic product up to, and of course we're the black line at the top, up to 16%. So rising costs are a concern, and a lot of the impetus for health reform, health system reform, has been to try to control these costs. Now here in the U.S., we had an additional concern about the significant numbers of the uninsured. However, our experience with the recession has reminded us of another side of the coin, and Yank referred to this, the significant contribution that the healthcare sector makes to the economy. We were also reminded that in hard times, people avoid seeing a doctor. As a matter of fact, over the past 4 years, there was a reduction in office visits in the U.S. associated with the recession. However, what we also have learned is the healthcare sector in general suffered much less than other parts of the economy, and doctor visits actually rebounded over the past year here in the U.S. And also, referencing Yank's comment, here in Jacksonville, the healthcare bioscience sector is at 16%, the biggest industry, and that percent actually increased during the recession. As Yank pointed out, that's because the top number went down, but in any event, it did increase and continues to increase. And to follow this point and illustrate the significance of the economic impact, in this case, of just one part of the healthcare sector, last year, the AMA commissioned the Lewin Group to do an economic impact survey of office physicians in the 50 states and the District of Columbia. Nationally, some 638,000 office-based physicians accounted for $1.4 trillion in economic activity and 4 million jobs. This contribution to the economy, as a matter of fact, in almost all cases, exceeded that of each of the following other sectors: hospital, legal, nursing home, home health. And here in our state of Florida, the 39,000 physicians accounted for 230,000 jobs, an average of 5.9 per physician. That's the extended impact. And the economic impact for Florida was $64.5 billion, 8.6% of Florida's gross domestic product. This included some $4 billion in wages and benefits and $2.3 billion in state and local taxes. Now, this takes me to talking about what I believe are the primary forces bearing on the discussion at this point. And just to get Yogi Berra out of the way, anything you hate to predict, you really hate to make predictions, especially about the future. So the forces that determine the nature of healthcare worldwide, and especially in the United States, and that will impact how we prevent disease, treat the ill, and protect against financial ruin. And there are three. The first, research-based scientific advances will continue to astound us with innovative and creative ways to care for the sick. We'll see more and more new ways to diagnose, to test, and to treat. And number two, an aging population and an accompanying epidemic of chronic disease will be a fact of life. And the third, at least particularly here in the U.S., healthcare system structural changes in delivery and payment will emphasize continuity of care and coordination, investments in quality, prevention, and wellness. Now, just to talk a little bit about the first, in my career in general internal medicine, I have been continually amazed and awed by advances in science. The tests, the treatments, the medications, the vaccines that seem to me to flow in an ever-building torrent from laboratories and clinics of inquisitive and imaginative scientists. And it's hard to imagine that this will do anything but increase. In fact, history would suggest we are more likely to underestimate its pace than to overestimate it. And I was reminded of this promise of discovery earlier this year when I was privileged to host the molecular biologist James Watson, who spent the day in my hometown of Winter Park. He was visiting the Morris Museum, which I'm sure some of you know houses the world's largest collection of Tiffany glass. Happy to report we managed not to break anything. Now, most of you in this room will remember, well, perhaps for some of you not remember, but know, that Watson, along with Crick and Wilkins, was awarded the Nobel Prize in 1962 for deducing the double helix structure of DNA some 9 years prior to that. Incidentally, Watson was only 25 when he made this discovery. Sort of begs the question, what are we all waiting for? And you know, you read that and you say, it really makes you want to go out and do something. Now, if that were not enough, in 1990, Watson was named head of the Human Genome Project at the National Institutes of Health. He later resigned because he objected to the idea that we might patent genomes. But first, he became one of two persons to have their fully sequenced genome published on the web. And he said he did it, quote, to encourage the development of an era of personalized medicine in which information contained in our genomes can be used to identify and prevent disease and create individualized medical therapies, end quote. This, of course, is revolutionary stuff. Now, James Watson's genome sequencing a few years ago cost $1 million. Today, you can go on the web and find that same study advertised for less than $2,000. And the number of genetic tests has exploded. A recent United Healthcare study found that $5 billion was spent in 2010 on genetic testing, and that is expected to go to 15 to 20 billion by 2021. And United Healthcare also estimates that there are currently some 1,000 to 1,300 tests available for 2,500 conditions, and that several new tests are being developed each month. Now, the sequencing of the human genome represents the largest single undertaking in history of biological science, stands as a signature of scientific achievement. That project was an international public project led by the U.S. and a complementary private program. It meant sequencing 3 billion DNA base pairs and identifying each gene. Our federal government invested $5.6 billion, and the calculations of the return on investment are about 141 to 1. And what this has meant is $796 billion in industry and research economic activity, some $244 billion in personal income, 3.8 million job years of employment, and just in 2010, federal taxes of some $3.7 billion and state and local taxes of $2.3 billion. And experts suggest that the years ahead will bring new and maybe unexpected solutions to contemporary issues in drug delivery technologies, pharmacogenomics, gene regulation, and manipulation. And we will learn more about the genetic variations that affect responses to hormones. We'll learn more about drugs and develop drugs to tailor treatments to individual patients. And by any measure, this era of personalized medicine reflects a potential explosion in science. Now, point number 2, the demographics. For starters, the world is getting older. It's estimated worldwide that the number of people aged 60 and older will double from the year 2000, when it was 600 million, to an anticipated 1.2 billion in 2025. And the U.S. population older than 65 increased from 12 million in 1950 to 26 million in 2004. We're expecting another 50% increase by 2050. And we know that advancing age brings an increase in what has become an epidemic of chronic disease, diseases like hypertension, heart disease, cancer, diabetes, lung disease, and others, the leading causes of disease. And this epidemic of what's now called non-communicable disease, or NCD, is worldwide and not just in the developed countries. NCDs are now the leading cause of disease and death, also in underdeveloped countries. And the burden of infectious disease, a burden that we associate with those countries, has not decreased, making them doubly burdened. The world is also getting heavier. Globally, obesity ranks now 4th as a major cause of morbidity and mortality, and is moving up fast. And as you know, in the U.S., it is 2nd in this dubious death rates, only to smoking. The maps you see on this slide, starting at the upper left, going to the right, and then down left to right, began in 1991 and go to 2008-2010. They show the percent obesity per state is measured by a BMI of equal to or greater than 30. White means it was not reported, and there's a few there on the top left. The pale blue, which is the dominant color back then, reflects 10%, less than 10% of the population. The bright orange, which is primarily where we are now, the right lower corner, means equal to or greater than 30% obesity of the population. The expectation is that this will affect some 42% of Americans by 2030 at a cost of $500 billion. So from these observations, I think some implications are clear. An escalation in diabetes and associated diseases and the challenge of treating them, a growing importance in the management of aging, and I would say, again, all of these problems are worldwide. And this is going to put a further strain on the physician workforce. The United States is already facing a growing shortage of physicians in many specialties, especially in primary care. And incidentally, I will not cover the items on this slide, which are some of the solutions, and it's part of the work that has to be done. And across the country, medical schools are expanding their class size, and new schools, and we know this certainly in Florida, new schools are coming online. And the Affordable Care Act includes a number of initiatives, which you see here, to provide incentives to primary care physicians through the National Health Service Corps, scholarship and loan repayment programs, to train more primary care physicians through Title VII Health Professions Program, establishment of a National Commission on Workforce, which is included in the Act, to align federal health care resources with societal needs, including especially primary care, grants to support adoption of the patient-centered medical homes, establish residency programs at teaching hospitals. In addition, there are provisions for a 10% bonus for primary care physicians, increases in Medicare payments for 2014 and 15 Medicaid payments equal to Medicare, establishment of a Center for Medicare and Medicaid Innovation, redistribution of unfilled residency positions to primary care and general surgery, and giving states the option to enroll patients in primary care medical homes. Which leads to my third point, and that is that, to emphasize again, internationally countries will continue to tweak their existing systems, and the U.S. will and is in the process of making changes of a greater magnitude in the structure of our health system. And a lot of that change will revolve around payment and delivery reforms. Reforms aimed at improving the quality of care, access to care, and how care is delivered, while addressing the problem of increasing cost. If health system reform is to work, as currently visualized, new payment and delivery models must succeed. Otherwise, we will go down the tubes. And physicians need to have a hand in developing them, as well as others in the healthcare sector. And because of this, the AMA and all of its partners in the Federation of Medicine established a physician payment reform and delivery leadership group. I call it a think tank, made up of practicing physicians. The goal of that group is to improve our understanding of how new payment and delivery models work, how they can provide financial stability for physicians while improving patient care. This group is establishing a framework to advance physician guidelines for new delivery models, such as, but not exclusively, accountable care organizations. We believe those models, if they are to succeed, need to be physician-led, be voluntary for patients and physicians. There should be flexible organizational criteria, not a one-size-fits-all. There should be support in these models for independent and small practice physicians, not small physicians, but small practice physicians, and maybe small physicians as well. And there should include, it also should include some antitrust and fraud and abuse reform. By the way, that area is an issue which is not exist around the world, so they do not have that particular challenge. And also these new systems should use quality measures that are driven by physicians. Now, the initial federal draft rules for ACOs included burdensome requirements and high financial risk for physicians and an unsustainable business model. Basically, everyone, and I'm sure you as well, looked at that and said, no way, Jose. So Organized Medicine pointed these problems out to the Centers for Medicare and Medicaid Services, and late last year, the final rule was issued that incorporated many of medicine's suggestions. And so thanks to that work by Organized Medicine, what seemed like a missed opportunity now seems like at least a possibility, and a possibility not just for a few select healthcare systems that already have advanced infrastructure and technology, but for physicians in a wide variety of practice settings around the country. And as a matter of fact, Of the 154 organizations that have been announced to date as qualifying under the Accountable Care Organization regulations, almost half are physician-led. Now, in addition, there are 300 ACOs already in this country operating in the commercial marketplace. I think a reminder that regardless of the direction taken as it relates to Medicare and government programs, private industry has already been moving down the train down this track. So science, demographics, structure will play an important role in the future of healthcare worldwide, and especially have an especially strong impact in the U.S. Now, this is the point at which my father, the minister, would say, this is the exhortation. 50 years ago, and it doesn't seem that long, at least not to me, President John F. Kennedy gave a speech at Rice University in Houston, and in the can-do spirit of the space age, Kennedy talked about the conquest not only of physical and technological barriers, but of psychological ones. I love that name of the Mars rover, Curiosity. And he said, we choose to go to the moon in this decade and do the other things, not because they're easy, but because they're hard. Because that goal will serve to organize and measure the best of our energies and skills. Because that challenge is one we are willing to accept, a challenge we are unwilling to postpone, and one we intend to win. Well, Kennedy called on our country to expand its horizons, accept daunting technical and scientific challenge, and to own it, not because we could, but because we should. So is the job we have ahead of us difficult? Yes. Is the path long and winding? Absolutely. Is success assured? Absolutely not. All the more reason to embrace it. You see, health system reform is our moonshot. Thank you. Thank you.
Thank you very much, Dr. Wilson. Do we have any questions that we have just a few minutes, or any comments from the audience? We have microphones in 4 areas, so just hold up your hand and they'd be happy to come to you.
My question had to do with the issue of technology and whether the World Medical Association, I think it's fitting that, with Apple today, it's a big announcement, our generation may look back and say the phrase, an apple a day keeps a doctor away, doesn't refer to fruit anymore, but really to technology. And so can you talk a little bit about the role of technology, particularly in developing countries, and use of that?
Let me just mention one area where there is a challenge that's being dealt with now, and this has to do with the fact that increasingly pharmaceutical companies are finding that economically it makes sense to them to do their clinical testing of new drugs, vaccines, whatever, in economically underdeveloped countries. It costs less. And increasingly, those countries are saying, so you're coming to our country and using our people, using our viruses. They're not proud of the viruses, but they are their viruses, the hantavirus and a number of others. And you're developing treatments and vaccines and opportunities which no one in our country can afford. That has become a big issue internationally, both and we have talked about a lot at World Medical. It's a big issue related to the World Health Organization. And so a lot of steps are being made by the pharmaceutical companies to develop these products at a cost which is affordable by these underdeveloped countries. Now, the irony, of course, is the developed countries are paying that differential in price. But so efforts are being made in that regard. And I guess the other observation as a general thought is technology allows us to do a lot of things more simply. It allows us to invent devices that can be used in underdeveloped countries. So, and this is not related to medicine specifically, but that little green laptop with the ears on it, that you wind it to make it work, which can be distributed for very little to countries around the world. And the same thing with handheld phones. So technology is not an unmixed blessing, but it will allow us to do things we never dreamed of before.
Number one, I can't help but notice that everything is geared toward more doctors, more technology, how to fix people once they're sick, as opposed to all the things that we know we can do to keep people from getting ill, so obesity, diabetes, heart disease. I don't see a lot of programs being pushed vigorously by the healthcare community to see that we reduce these diseases. That's one thing, and which I'd like you to address. And number two, you made the statement that uninsured is in the United States is like in undeveloped countries. And it seems to me like we've got an excess of 20 million patients a year that are being seen that have no insurance. I know of in emergency rooms. I don't know where else. So they are getting some care. I mean,
to have access to care just be the emergency room is good when you get hit by a car, but it's not good when you need to be followed for your hypertension, for your diabetes, when you need testing to prevent disease and to anticipate disease. So we have some challenges. It's not like they get no care, and that's the case in some of the underdeveloped countries. If they can get to an emergency room, they can get care, but it's not 21st century medicine, or even 20th century for that matter. Your first point about the issue of prevention is right on target. 78% of what we spend in healthcare in this country is for chronic disease, by and large preventable. This is a societal problem, will not be solved by physicians seeing one patient at a time in their office. And I think the good news is that this is increasingly being recognized. So when we talk about non-communicable diseases and we talk about solutions there, we're talking about how do you prevent it? How do you address issues related to smoking and lack of exercise and obesity and those kinds of things. So prevention is the only way we're going to get a handle on that. The other sort of term du jour worldwide is what's called social determinants of health. And we know now that the economics of a country have an effect on people's health. How the cities are constructed, whether they're parks or places people can exercise, makes a difference. So those are all things that, unless we tackle those, the good news is they are preventable. The bad news is we're talking about human behavior, and that's going to be a long road to hoe. But I am actually encouraged that we are addressing those in much the same way that we addressed cigarette smoking some 3 or 4 decades ago, and we're now down to 20% now, so we still have cigarette smoking. Those kinds of things are challenges. But anyway, thank you.